Hello, and welcome to the Bariatric Surgery Seminar of the Weight Loss Surgery Center from Sangre de Cristo Surgical Associates in Parkview Medical Center in Pueblo, Colorado. I am Dr. Sergio Toledo, and in this presentation, I will give you an overview of the program and what can a patient expect when entering it. But before doing that, I would like to start by answering a couple of questions that many patients have. What is exactly weight loss or bariatric surgery? It's basically surgical changes to the stomach and or the small bowels. With these changes, there will be an impact in the patient's appetite and thirst, how much food the patient will be able to eat, but most importantly, the way the nutrients are going to be absorbed through complex hormonal pathways. It may also change the patient's set point by increasing the basal metabolism, and I will explain this further with the next couple of videos.
So how does bariatric surgery work to help people lose weight and maintain that new lower weight? Most people, even many doctors, think that bariatric surgery works only for restricting food intake or preventing calories from being absorbed. This is true, but there is more to it. Research suggests that certain types of bariatric surgery also affect the signals between the brain and the body and cause decreased appetite, increased feelings of fullness, increased metabolism, and even preferences for healthier food. These surgeries appear to produce signal changes that reset the body weight set point to a new healthier level and stop the brain from encouraging weight regain in response to dieting. Bariatric surgery may also affect hormones that help to regulate your overall health, which may explain why some types of bariatric surgery can resolve or improve type 2 diabetes. The set point theory suggests that no matter what you want to weigh, your brain has a certain weight range and body fat level that it works to maintain within the set point range. This means that you don't control your body fat consciously. Rather, your brain manages it like it does your breathing and heart rate. Your brain receives information through hormone signals from your body fat, muscles, pancreas, liver, GI tract, and sensory organs at all times, and controls your appetite, digestion, energy balance, and metabolism. Once your set point has been elevated, your body works to defend it vigorously. What happens when Amanda starts a diet? She might be able to lose some weight temporarily, but hormone signals from her body change in response to weight loss and tell her brain to increase calorie intake and slow down calorie burn to restore the body fat she's lost. She feels hungrier, and although she doesn't know it, she's also burning calories slower than before. Amanda's body doesn't recognize that her set point is too high and her weight is unhealthy. It only knows to defend her current set point.
Now, another very common question the patients have is how safe weight loss surgery is. In reality, it is very safe. The possibility of dying with this type of surgeries is about 0.1%. This is a much lower probability when we compare it against two of the most common surgeries performed in the US, like gallbladder or hip surgery. With every surgery, there are always some possible risks, and with bariatric surgery, the risk of a complication, depending on the type of surgery, is about 4%. Weight loss surgery is not only about the weight. Personally, it's more about improving or curing the weight-associated diseases and therefore improving the quality of life. These are some of the over 40 weight-associated diseases: type 2 diabetes, high blood pressure, high cholesterol, heart attacks, stroke, acid reflux, sleep apnea, joint disease, depression, polycystic ovarian syndrome, severe urinary incontinence, or cancer like ovarian, breast, colon, pancreas. Yes, weight is very important, but these other diseases will have a huge impact in the patient's health. It is very important to understand that surgery is not the magic bullet, but rather a great tool to help the patients lose weight, improve or cure the weight-associated diseases, and reach their goals. It is all about the change in patients' lifestyle and the mindset. Otherwise, surgery is not really the answer. It would only work temporarily, if that. And usually what happens is the patient loses weight after surgery, only to regain it later and usually surpassing the weight before surgery. How would a patient know if surgery might be something good for him or her? Well, if patients answer yes to these questions, then surgery might be a good option for them. Do you want a healthier life? Do you want to control your diabetes, high blood pressure, heart disease, arthritis, sleep apnea, or other conditions? Are you motivated and ready to change your lifestyle? Now, who qualifies for weight loss surgery? In order to answer this question, we need to understand that one of the most important concepts around weight loss surgery is the body mass index, or BMI, which is a combination between your weight and height. You can see the formula at the bottom of the slide. A healthy BMI goes between 19 and 25. Patients with a BMI above 40 qualify for surgery. Also, patients that have a BMI above 35 plus one weight-associated disease qualify for weight loss surgery as well. There are mainly two surgeries that we performed here at the Weight Loss Center, the gastric sleeve and the gastric bypass. Both of the surgeries are done with minimally invasive techniques, which is creating small holes in the skin and using a video camera as well as long instruments like chopsticks with different tips. The sleeve gastrectomy is the most common surgery performed nowadays in the US and worldwide for the past 10 years. It usually takes between 45 minutes to an hour and a half to do, and the long-term complications are few. Basically, it involves the removal of the outer part of the stomach with a very sophisticated stapler to create a new stomach that looks like a banana and will be able to hold between 50 and 150 milliliters of fluid or food. By doing this, we're not only making a smaller stomach, but also in the removed stomach are hormones involved in the regulation of hunger and thirst, which, through complex pathways, will decrease fat formation. Since we are not touching the small bowel, there is no malabsorption involved. The drawbacks of the procedure are, in the acute setting, leaks or bleeding from the staple line that can cause an infection that might require further procedures to control it. Also, over time, it can cause some narrowing on the new stomach that might require stretching of the narrowed area and or another surgery. Lastly, it can cause acid reflux. It is important to consider that this procedure might not be the best option for patients who have acid reflux at baseline, since it can cause more acid reflux in about 30 to 40% of the times. This video will help you understand how is the laparoscopic sleeve gastrectomy done.
To access the abdominal cavity, small incisions are created. Trocars are placed to serve as passageways for surgical instruments. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes. These help break the food down into a simpler form so that it can be digested more easily and absorbed in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters and is about the size of a banana. The resected portion of the stomach is removed. By altering the anatomy of the gastrointestinal tract, sleeve gastrectomy changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. Bile and pancreatic fluid from the liver and pancreas mix with food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or postoperative adjustments needed for the sleeve gastrectomy. As with all weight loss procedures, Behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
The gastric bypass has been around for over 25 years, and most of the data that we have in weight loss surgery comes from this procedure. As stated before, it is also done with minimal invasive techniques. It is technically more challenging than the sleeve gastrectomy and takes between 2 to 3 hours to do. It consists on creating a new stomach that we call the pouch, and has usually the size of an egg that will hold between 1 and 2 ounces of fluid or food. Also, somewhere in the mid-small bowel, a loop of intestine is brought up and attached to the pouch. The way the food will go through your body is down the esophagus, the pouch, and to the small bowel, bypassing the stomach and the first part of the small bowel, which is the most important area for absorbing the nutrients. The food is going to meet the stomach, liver, and pancreatic juices through another connection that is created downstream so the food can be broken down and be absorbed. With the surgery, we are not only creating a smaller stomach, but also changing the hormonal pathways that are involved in appetite and food absorption. This surgery is the standard of care in patients with acid reflux. On the other hand, this procedure might be a better option for diabetic patients, especially patients that use a lot of insulin or multiple medications. The data shows and supports that the gastric bypass controls or cures diabetes better than the sleeve gastrectomy. I'm not saying the sleeve gastrectomy does not work for improving diabetes, but based on the literature, the gastric bypass seems to be superior in managing diabetes. The long-term drawbacks of the surgery are, since we are rerouting the intestines, risk for internal hernia formation and malabsorption. This video will help you understand how is the laparoscopic gastric bypass done.
To access the abdominal cavity, small incisions are created. Trocars are placed to serve as passageways for surgical instruments. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes. These help break the food down into a simpler form so that it can be digested more easily and absorbed in the small bowel. During a gastric bypass, a small pouch is created in the stomach using a stapling device. The small stomach pouch, about the size of an egg, limits the amount of food you can eat before feeling full. The small bowel is separated into 2 sections. The lower portion of the small bowel is attached to the newly created stomach pouch. This allows food to pass directly into the second portion of small bowel, where digestion continues. The upper portion of the small bowel is reconnected to the lower. Bile and pancreatic fluids from the liver and pancreas allow food to be digested completely. By altering the anatomy of the gastrointestinal tract, gastric bypass changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals.
Does weight loss surgery work alone? In short, no. As I mentioned previously, surgery is not the panacea. It is a tool. In order for this tool to help the patient, it requires hard work. I'm not going to lie. The journey of a weight loss program is like this picture. A long and difficult road, full of obstacles, but it is very doable, with amazing results and rewards at the end. Also, it is important to understand that the patient will not be alone. During this journey, a great team of people will be working alongside the patient so the goals can be reached. But we can't do the work for the patient. The patient has to do it. What is the process of this program? First is the seminar. Second, the patient will see me or one of my partners in the office. In this visit, the patient will be asked to fill some intake forms and the bariatric surgeon will perform a complete history and physical exam. An informational packet will be provided. In this folder, aside from information about obesity and the website link, a welcome letter will be found that has at the bottom of it a QR code. This code allows the patient to see the bariatric guidebook online, or as we call it, the Bariatric Bible. In the guidebook, as well as the website, the patient will find a lot of information in regards on how to prepare for surgery, what to expect after, and multiple resources that will help the patient during the program. Likewise, a list with the contact information of the different specialties that the patient will be referred to. The specialties are psychology, dietitian, and physical therapy. Based on the surgeon's evaluation, the patient might be referred to other subspecialties like cardiology, pulmonology, gastroenterology. Monthly visits with the primary care physician where weight counseling will also take place. From the primary care physicians, we will obtain the most recent labs as well as the results from multiple age and gender-specific screening tests like pap smear, mammography, and colonoscopy. If the tests are due, they will be ordered. Visit with a psychologist. Dietitian consult. I strongly believe that this is one of the most important parts of the process because appropriate and healthy diet has a lot to do with the success in weight loss. Physical therapy is also crucial, especially for patients whose mobility is limited. We already discussed the possible need for evaluation from different subspecialties. Once we have all the prior steps, insurance approval comes next. Of note, it is critical to check early on in the process with the insurance company and see if the patient has weight loss benefits. Having insurance does not mean that coverage for bariatric procedure is guaranteed. There are some insurances like Medicaid, Parker, and Anthem that require 6 months of monthly follow-up with the primary care physicians where weight counseling has to be addressed before authorizing surgery. Once we obtain the authorization from the insurance, we proceed with surgery. Which procedure, you might ask? For the most part, it depends on the patient's decision based on the education they had. We like to provide the patient with all the possible information so they can make a true informed decision. We'll also guide the patient's selection based on their medical conditions. Lastly, lifetime follow-up. It is critical that the patient continues to see a physician versed in weight loss procedures because that way he or she will be able to detect early on potential problems. Usually, if everything goes well, the follow-up visits after surgery are 1 week, 1 month, 3 months, 6 months, plus minus 9 months, 12 months, and yearly after. I think this is one of the most important slides for the patients. What are the expectations after surgery? First, to be able to cure, and if not, at least have better control of the weight-associated diseases. In the case of diabetes, close follow-up with the primary care physician is imperative because patients can have big swings in their sugar levels. Some patients drop their sugar level dramatically right after surgery, and some elevate them initially due to a response from the surgery itself, and shortly after, they drop. Control or cure of high blood pressure, resolution of sleep apnea. This usually happens between 6 and 9 months after surgery. In summary, improvement in the weight-associated diseases. Furthermore, it is expected to lose between 50 and 70% of the excess body weight after 1 year of surgery. I will explain this concept with the following example. Based on this hypothetical patient whose height is 5'8" and weighs 290 pounds, his body mass index is 44. Our goal is to bring this patient to a healthy body mass index of 25. It's important to understand that we are not planning to transform people into Victoria's Secret models or Avengers characters. That is unrealistic. We are trying to help people to reach a healthy state. Now, for reaching a BMI of 25, the weight for this person should be 160 pounds. The difference of 290 and 160 pounds is what we called the excess body weight. So, the expectation is that the patient will lose between 65 and 90 pounds after 1 year from surgery. Afterwards, It depends on each patient based on their lifestyle change to stay there or continue to lose weight. Now, between the psychologists and the dietitians, the patient will be assessed for eating behaviors and disorders. Their weight loss attempts will be discussed, and they will teach them how to do the important dietary and mental changes prior to surgery. It's important to remember that hydration in general is necessary, but crucial after bariatric surgery. The recommendation is to drink at least 64 ounces of water per day. After surgery, the number one reason why the patients come back to the emergency department is because of dehydration. This is because the thirst center gets altered after surgery, with either surgery, and patients do not feel the need to drink water initially. By the time they are thirsty, it's usually too late, and the patients develop nausea, vomiting, abdominal pain, and are unable to tolerate anything by mouth. So, in order to prevent this, I always advise my patients to start training and changing their habits about hydration. I recommend to buy a bottle of water, whichever kind, size, shape, or color. This bottle will need to be with them at all times, like a cell phone nowadays, and be sipping water throughout the day instead of chugging a huge amount at a time. Intuitive and mindful eating does not mean to eat a whole chocolate cake when you're craving a slice. It is learning what the craving is telling you and interpreting the message. Food has a remarkable way of connecting us to those feelings or disconnecting us from our physical and emotional selves. It's important to recognize and understand that biochemical and emotional processes are linked. With time, we learn emotional eating and unlearn intuitive eating. For example, eating cake at birthdays, pizza with a sad friend, and ice cream after winning or losing a baseball game. Emotional eating is basically a learned response that becomes a bad habit over time. It's important to start taking a multivitamin with iron daily to fill up the tanks of the vitamins and supplements that our body needs. 2 weeks prior to surgery, the patient will be provided with a liver shrinking diet. The purpose of the diet is, as its name says, to decrease the size of the liver that usually in obese patients is not only large, but very heavy. In order to perform the surgery, the left side of the liver needs to be lifted to access a critical area where most of the surgery will be held. Having a smaller and lighter liver before the surgery will not only make the surgery easier, but improve the outcomes. After surgery, we divide the diet in 4 stages. The first stage is right after surgery and consists of a clear liquid diet, which is basically a sugar-free, see-through liquids. Stage 2 usually lasts from day 1 or 2 up to 3 weeks after surgery and is a full liquid diet. Again, is mainly sugar-free fluid, but has more consistency. Stage 3 ranges between 3 and 10 weeks after surgery and is a soft, moist food diet. And finally, stage 4 is after 3 months of surgery and basically for life. Consists of a low-fat solid diet. I can't stress enough the importance of hydration. 64 ounces of water a day. Protein will become the primary source of energy after surgery. Therefore, between 60 and 80 grams of protein should be consumed daily. And finally, patients will have to take daily multivitamins with iron, calcium supplements, vitamin D supplements, as well as vitamin B12 supplements. Blood work will be obtained at 6 months from the surgery, 1 year after, and yearly after, with the objective to assess the need to increase or decrease certain supplements. The main challenges after surgery are dumping syndrome, which is a physiologic response to simple sugar. After surgery, they get dumped into the small bowel without a lot of digestion, and these sugars increase the amount of water that is pulled into the bowels from the blood. This excess water now propels food rapidly, causing diarrhea along with nausea, increased heart rate, abdominal cramping, sweating, weakness, and dizziness. Nausea and vomiting usually are due to dehydration. Again, our number one reason for readmissions into the hospital. Diarrhea alone is usually to the alteration in the anatomy of the bowels from the surgery. Usually after some time, it resolves. but if left without attention, could lead to dehydration. Constipation is mainly due to the amount of narcotics that the patients get. Therefore, we try to minimize its use and tend to control pain in a multimodal fashion. This is using different types of non-narcotic medications. Food intolerance can be due to dehydration or due to excessive food that gets eaten in a very short amount of time. Acid reflux, as I mentioned before, can be present in about 30 to 40% of patients with a sleeve. In a gastric bypass, this is more rare. We tend to control this issue by prescribing the patients acid reducers, named proton pump inhibitors or PPIs, for 3 months after surgery. As a quick side note, patients that have surgery and still have their gallbladder will need to be on a special medication for 6 months to prevent stone formation from the rapid weight loss that can lead to an unwanted procedure. The patient will have us as a team, but in order for this to work, it has to be a two-way street. Therefore, we also have some expectations from the patients. Patients need to be committed to change their lifestyle and start taking charge of their own health and life. Not being 100% with the program or expecting someone else to fix their problems will only lead to failure. No more food funerals. There are some patients who like to have this Thanksgiving type of meals before starting the program, before seeing a provider, or worse, before surgery. These patients are not really committed, and data shows that they tend to do poorly after surgery. The patient will need to be compliant with appointments and with taking their medications. The patient will have to follow up on their own test results. We have a very strict non-smoking policy, not because I want to dictate how the patients should live their lives, but because the risk of having surgery while smoking or smoking after surgery puts a great outcome in jeopardy. And not only that, the chances of complications increase exponentially. Being a smoker does not mean that the patient can't be in the program. Of course they can. But I will not take them to the operating room while still smoking. During the process, they will have to quit, and we can provide them with resources to aid in this matter. Before surgery, I will test them to make sure that there are no traces of nicotine in their bodies. If the test is positive, we will cancel the surgery. Lastly, physical activity. Being active is also an essential element for success. When I created this program, I did it knowing that the only way to succeed was through a team approach, and I truly believe in this concept. With this in mind, a multidisciplinary team was created consisting on primary care physicians, psychologists, dietitians, physical therapists, specialists, surgeons. Everyone in this team wants to help patients, and we are more than 100% committed. There's only one objective in mind: the patient. Now, let's put some faces to the names so you can start familiarizing with the team. Again, I'm Dr. Sergio Toledo, bariatric surgeon and director of the weight loss program. Dr. Anam Paul is my partner and also a bariatric surgeon. Ramona Gurula is, in my opinion, the most important person in this program. She is our bariatric coordinator, basically the glue between providers, staff, and patients, who keeps me in line. In other words, keeps this program up and running. Also, she's a fantastic point of contact and is always available to answer any questions or concerns the patient might have before and after surgery. Jennifer Soler is our outstanding medical assistant who is in charge of the outpatient coordination between offices and handles all the overwhelming paperwork. Dr. Erin Ashby is our marvelous psychologist that will evaluate the patient's state of mind, how well their coping mechanisms are, and assess their support group. Stefan Braz is the director of the Outpatient Rehabilitation Center, who, with his outstanding team, will help patients to obtain all the physical therapy they need before and after surgery. Tara Gild is our dietitian manager, and along with her wonderful team, including Cindy Moses and Lindsay Talaxon, will provide the crucial nutritional management and education to the patients before surgery, during the patient's hospital stay, and after surgery. Kimberly Filson and Chelsea Hope lead the group of amazing nurses that take care of the patients while in the hospital. Our commitment is to help patients reach their goal. Thank you very much for watching this presentation. Hopefully, it provided you with useful information. Have a good day and see you soon.